right, let's call this meeting to order. The commission is starting a few minutes late because we had an administrative session to discuss budgetary matters. Agenda item number 1 is approval of minutes. Included in your packets are copies of the minutes from the October 20th meeting of the commission. If there are no changes or corrections, I'll entertain a motion for approval. Second. Any discussion? All in favor? Any opposed? Minutes are approved. Commissioners, you've received a written update from our centers. Ben, do you or any other center directors have something you'd like to add?
Thank you, Mr. Chairman. I believe we have one update from our health facility planning group.
Kathy?
Good afternoon. At last month's meeting, the Commission approved the staff recommended quality measures and performance levels to be used in the upcoming Certificate of Need review of Home Health Agency projects. As discussed, the quality metrics vary by type of applicant. For hospital applicants, the performance threshold of 3 stars or greater on CMS's Hospital CAHPS Summary Star Rating will be used. You asked staff to clarify whether the hospital summary star rating of 3 stars or greater related to Maryland or to the national experience of care data. In response, staff reaffirms that the summary star ratings are based on national data, and we have provided for you in your update, for your information, the CMS table titled Distribution of Hospital CAHPS Summary Star Ratings by State. As shown in this table, about 60% of Maryland hospitals met the performance threshold of 3 stars or better, compared with about 80% of hospitals nationwide. Staff recognizes that while there are better performing hospitals nationally, meaning that Maryland has a greater proportion of its hospitals performing below 3 stars, it is our intention to not lower the bar for Maryland hospitals, but to hold them to the same 3-star performance threshold. Thank you.
Any questions for Kathy? Thank you. Any other updates? If not, we'll move on to agenda item number 3, the state health.
Can I just ask a question about what was in the written update? There was a mention of a hospice survey and that you would be drafting one or it's close to draft. I was wondering if that was something we could take a look at.
There is an annual hospice survey. Some of the hospices had said they wanted us to talk about making changes in that.
Okay.
So we're having a meeting with them next week to talk about some of possible changes to the current question.
Okay. Is that something you would mind if I wrote shotgun?
Sure.
Okay. So if I can see the draft?
I would send it to the whole commission.
Okay.
That's great.
Thank you.
Any other questions? All right. Agenda item number 3 is the state health plan for facilities and services, freestanding medical facilities chapter of proposed regulations. At the July meeting, the commission adopted the freestanding medical facilities chapter of the state health plan for facilities and services as proposed regulations. The commission later received formal public comments and also spoke with staff, legislative committee, and the Division of State Documents. As a result, some substantive changes, as well as some minor changes, are recommended by staff, who will be again asking the commission to adopt the proposed permanent regulations today. So Eileen Fleck will summarize the comments received on regulations adopted in July and will present staff's recommendations for adoption of revised proposed permanent regulations. Eileen?
Good afternoon, Mr. Chair and Commissioners. I'll review most of the formal comments on the proposed FMF regulations, but not all of them. All of the comments are included in the staff memo that I sent to you. And I just want to mention that we received comments from 4 organizations or individuals: the City of Tacoma Park, Holy Cross Health, the University of Maryland Medical System, and David B. Paris Esquire. In Regulation .02, which describes the applicability of the regulations, Holy Cross Health commented that it's unclear if existing FMFs can only operate in their current capacity without seeking a certificate of need, or if the existing FMFs can make changes to the scope of their services or the facility design without obtaining a certificate of need. We are not recommending changes in response to this comment because we've concluded that the applicability of the regulations is clearly stated. We note that the regulations allow for changes in the scope of services or facility design when those changes will not result in a capital expenditure that exceeds the threshold, or a new service that is categorically regulated under CON is not being introduced. Staff received comments on the project review standard for need from Holy Cross Health, the University of Maryland Medical System, and the City of Tacoma Park. Holy Cross Health again expressed concern about whether an expansion of services at an existing FMF would trigger a CON review. The University of Maryland Medical System suggested that an FMF should not be required to be designed to have treatment capacity and space consistent with the standards used for the design of emergency departments designated as low range in the guidelines of the American College of Emergency Physicians, which are referenced in the regulations. The University of Maryland Medical System recommended that no quantitative guidance be included. The City of Tacoma Park commented that the administrative burden of CON review for the applicant should be minimized when a hospital is relocating and wants to put an FMF on the former campus. Staff is not recommending changes in response to these comments. With regard to the University of Maryland Medical System comments, we've concluded that if an FMF is needed to address overcrowding or access issues, which is when a CON would be sought, the volume and types of visits at the proposed FMF are likely to be below those for a low-range hospital ED in the guidelines referenced. Based on previous analysis by staff of the existing FMFs between calendar year 2012 and calendar year 2014, less than 6% of patient visits each year resulted in hospital admissions, which is well below the benchmark of 8% for low-range hospital emergency departments. In addition, there are ranges for the appropriate number of treatment spaces based on increments of 5,000 visits, and that allows for flexibility to account for variations in patient acuity and specialty programs. With regard to the comments from the City of Tacoma Park, we concluded that the standards are not as restrictive as described by the City of Tacoma Park, and note that no hospitals have expressed concerns about the administrative burden that was feared by the City of Tacoma Park. In terms of Holy Cross Health's comments, we think, as I mentioned just a minute ago, that the applicability of the regulations is clear. Staff also received comments from the University of Maryland Medical System on the financial feasibility and viability project review standard. The University of Maryland Medical System suggested that a proposed FMF be compared specifically to FMFs with similar projected visit volumes, projected patient acuity, demographics, and specialty programs, rather than simply with similar FMFs. Staff is not recommending changes in response to these comments because the actual experience of FMFs is most relevant, not hypothetical projections for other FMFs. Staff received comments on the impact project review standard from Holy Cross Health. It commented that the impact of a proposed project on the future accessibility and affordability of healthcare should be incorporated into the standard. Holy Cross Health also requested certainty that the global budget impact on the parent hospital and other hospitals near the proposed FMF be analyzed in the context of a longer time period, although it did not define what was meant by a longer time period. Staff recommends no change in response to the comments from Holy Cross Health. There are separate project review standards for access and cost effectiveness, and incorporating access and affordability into the impact standard is unnecessary. With respect to the time frame for evaluating impact, we conclude that the standard allows for consideration of the impact of a proposed project over several years, and the appropriate time frame to consider may vary for projects, so a flexible rather than fixed time frame is best. Staff received comments on the project review standard for quality improvement. The City of Tacoma Park commented that when a relocating hospital proposes the establishment of an FMF on its old campus, the Commission should deem that a quality assurance program for the proposed FMF meets the project review standard if it is identical to the one for the relocated hospital. Staff recommends no change in response to this comment because the specific performance standards referenced are appropriately tailored for general use and the types of project reviews that are reasonably anticipated for FMF development and will generally not involve relocation of a hospital. With regard to the exemption process for a general hospital seeking to convert to an FMF, which is described in Regulation 0.04C, only the University of Maryland Medical System had comments. These comments pertain to three topics: the timing of the exemption process, the use of the guidelines of the American College of Emergency Physicians, and the provision of surgical services at an FMF. The University of Maryland Medical System commented that the chapter does not comply with the exemption process established by the General Assembly in terms of the timing, and noted that the exemption process could take longer than the review of an uncontested CON application or slightly less than a contested application. The University of Maryland Medical System requested that certain requirements in the regulations be eliminated to address this issue. The University of Maryland Medical System also suggested that the Commission review the application in concert with the Maryland Institute for Emergency Medical Services Systems, rather than accepting an application only after MIMS has made a determination that the conversion will maintain adequate and appropriate delivery of emergency care. Staff recommends no changes in response to these comments. The regulatory process proposed by the University of Maryland Medical System is not feasible because following the required public informational hearing, there could potentially be fewer than 20 days for the Commission to make a final finding on the establishment of an SMS. Staff also notes that MIMS required assessment of a proposed hospital conversion to an FMS should precede Commission action rather than being undertaken simultaneously as proposed. Because under statute, the Commission cannot approve a conversion to an FMS unless MIMS finds that the conversion will maintain adequate and appropriate delivery of emergency care within the statewide emergency medical services system. I would add that an applicant will be sending information to MIMS at the same time that they're sending it to us. So there won't be a delay in terms of us seeing the information that MIMS is getting, if that's also relevant to us making a decision. In terms of the time allotted for reviews of exemption requests compared to the CON process, we've concluded that the exemption process will typically be much faster than a CON review because there can be no interested parties, there are fewer review standards, and the review standards are of a different nature. The comments of the University of Maryland Medical System on the use of the guidelines of the American College of Emergency Physicians are similar to those comments that it had on the use of those standards for Certificate of Need reviews. It had specific changes that it requested based on its concern that a proposed FMF may not be appropriately evaluated according to those guidelines for a low-range hospital emergency department. We're again recommending no changes in response to those comments for the same reasons that I mentioned. The University of Maryland Medical System commented that requiring surgical services at an FMS to be separately licensed as an ambulatory surgical facility conflicts with regulations of the Centers for Medicare and Medicaid for provider-based status. The University of Maryland Medical System also noted that the requirement for a separate license as an ambulatory surgical facility would preclude the Health Services Cost Review Commission from exercising its discretion to regulate rates at FMS. University of Maryland Medical System commented that the State Health Plan Chapter for General Surgical Services, COMOR 102411, refers only to hospitals and ambulatory surgical centers and not FMS. It also noted that statute excludes from the definition of ambulatory surgical facility any facility or service owned or operated by a hospital and rate regulated by HSCRC. The University of Maryland Medical System suggested that these issues be resolved by amending the definition of a hospital in COMOR 102411, the State Health Plan Chapter for Surgical Services. It believes that this change would permit FMS to seek to establish, relocate, or expand surgical services lines. Although the University of Maryland Medical System commented that requiring surgical services at an FMS to be separately licensed as an ambulatory surgical facility conflicts with regulations of CMS for provider-based status, HSCRC staff has advised MHCC staff that CMS exempted Maryland from that provision. Commission staff also concludes that changes to the definition of an ambulatory surgical facility in statute would eliminate the conflict identified by the University of Maryland Medical System. Parallel changes would also then be needed to be made in the definition of a freestanding ambulatory surgical facility in regulations for the Office of Healthcare Quality. The alternative approach suggested by the University of Maryland Medical System as a way to resolve the conflicts with CMS regulations and state regulations by amending the definition of a hospital in the State Health Plan Chapter for Surgical Services would likely require additional changes to the draft State Health Plan Chapter for FMS in terms of the CON review standards. We prefer to change the definition of an ambulatory surgical facility because we do not believe that the current law mandates creation of a hybrid medical care facility as desired by the University of Maryland Medical System that combines unscheduled urgent, emergency medical care, scheduled ambulatory surgery, and other yet to be defined services under a single FMF license. The establishment of FMF in Maryland law and the regulations of the Office of Healthcare Quality never envisioned that FMF would have operating rooms and all of the ancillary support space necessary for the operation of a surgical facility. Instead, we've concluded that allowing an ambulatory surgical facility to be established on the campus of an FMF would be the most appropriate approach. We're planning to propose revisions to the State Health Plan chapter for general surgical services to establish an exemption process that would allow an ambulatory surgical facility with up to 2 operating rooms to be developed on the campus of an FMF that is being established through conversion of a general hospital. Staff from the Administrative, Executive, and Legislative Review Committee, like the University of Maryland Medical System, also noted a conflict between the proposed regulations for FMS and the State Health Plan chapter for surgical services. AELR staff said that if surgical capacity is licensed as an ASF with 2 or more operating rooms, then a CON is required. In order to address this issue, as well as the issue regarding ambulatory surgical facilities and rate reimbursement for surgical services by HSCRC, staff recommends deleting language that references the addition of surgical capacity at an FMS developed through an exemption process. The proposed deletion is shown on page 9 of the memo that I sent to commissioners. There is one additional change that I want to mention that was initiated by staff rather than in response to comments. We're recommending that language be added to the CON standards for review that is consistent with the language already included in the exemption request in terms of evaluation of proposed observation space, which would be based on the current edition of the guidelines of the American College of Emergency Physicians. The exact wording is shown on page 13 of the staff memo to commissioners. That concludes my presentation. I would be happy to answer any questions before the commission considers staff's recommendation to adopt the draft State Health Plan chapter for FMS.
Okay. Do I have a motion to adopt COMAR 102419, the freestanding medical facilities chapter State Health Plan as proposed permanent regulations? Any questions or discussion? Jerry.
It seems to me that University of Maryland is kind of morphing the essence of a freestanding medical facility into something different. The true essence was the health overflow of emergency rooms in urban and suburban hospitals. And obviously their intent is to replace a hospital with a freestanding medical facility. And by their own request to change the definition of a hospital will basically be a hospital, 1 or more acute care beds. And we're talking about semantics, observation beds versus acute care beds in this FMS.
Well, I think I first want to just clarify. So initially we had these pilot projects established, and those were to address overcrowding and access issues. And then there was legislation that was passed that would allow for a hospital to convert to a freestanding medical facility. And so that's why we then delayed these regulations a bit, and we have written into these regulations a process for that. So that is something that is recognized as permissible, to have a general hospital convert to the freestanding FMS. I would say that in terms of the services offered, it's not clear that surgical services were contemplated, during the legislative session as being part of that, and so some other changes would probably be needed.
Well, that's what I'm saying. We're creating a different animal here with different size requirements, acuity level difference, volumes. And I agree with the University of Maryland, you can't hold a new FMF projection to the American College of ER physicians statistics and numbers, because it won't fit as a replacement. If it replaces a hospital, it's going to be different than a typical freestanding medical facility. I wonder if we're just creating something new here, entirely new, that's not the essence of the FMF.
Well, I would say the regulations, they cover hospital emergency departments and also FMFs, which are seen as maybe more like a low-volume hospital emergency department. And there are some specific things that are taken into consideration in terms of maybe allowing more space for an FMF.
Aren't there definitions of a low-volume hospital? Aren't there in existence?
Yeah.
Low-volume hospitals.
Yeah, that's correct. And we would.
What would be the difference between that and an FMS?
I would say there's not a difference in terms of the the guidelines and what they're saying.
Other questions?
Uh-huh. Uh-huh.
All right, can you hear me now? All right. So I'm on page 3 of the recommendations. I'm looking at 04B, the project review standards, and the proposed regulation refers to the low range. Proposed adding this thing about the applicable guidance of the current rather than the low range. Are we in that? In our evaluation, are we looking? I couldn't figure out if are we looking to make sure it's not too big, or are we looking to make sure that it's big enough? The freestanding medical facility.
I guess probably the fear is that it's not too big. I mean, if the visits are longer, if they're taking longer versus like quicker visits, then you would expect that you need more time and you can't get people through as quickly, and so you need more spaces for that situation. I would say that in terms of the number of visits and the spaces, the table that's in those guidelines, it has low and it has high. So there is not like a medium, it's just there's the low end and there's the high end, and then obviously things can be in between. It does, so there's not really an option for, well, let's say it's medium then.
We're looking at the number of treatment spaces to be consistent with the low range.
Right.
My second question, and these are not things I have a view on, but I'm trying to understand. It's a new area. The Holy Cross comment on item 7 on page 5 about looking at the impact of the project on future accessibility and affordability, and they refer to the global budget. Are these circumstances where a hospital is going to build a freestanding medical facility, move other things, surgeries and activities that otherwise would be within the global budget out into the freestanding medical facility, or is that not an issue?
There will be a specific budget for the FMF, but like the reason people have those is to address overcrowding or to address access, or a hospital is converting to a freestanding FMF. So like there are very specific circumstances for it. It's not a situation where a hospital could just decide like, well, I think that it would be better for us to put these things in a freestanding medical facility for, you know, some other reasons that don't fit within what we see as the appropriate reasons to build an FMF.
Right. I guess that was sort of my next question. The first one was, are hospitals going to be able to game the global budgets by building freestanding medical facilities? Commissioner O'Grady seems to be thinking that might be a possibility. If that were a possibility, though, is that even our role to consider? I mean, we generally look at whether there's a need and whether it's financially viable, and we give the certificate, right? Do we have a role in enforcing global budgets, or is that something that's properly left to the HSCRC anyway?
It's really the HSCRC that's going to be making decisions. I mean, I think their concern was, is it going to be, you know, very short-sighted, just based on like, okay, what's going to happen in the next year, versus something maybe over a few years, and what that impact might be on hospitals that are nearby and also the parent hospital.
Okay, I'm not sure if anybody has anything more insightful than my thoughts on that.
Eileen, I have just one question about the determination of legality here. What has happened is the Department of Legislative Services staff got together with the administrative, executive, and legislative committee staff, apparently, and they said what we were originally proposing was not correct legally, correct?
There were concerns raised about that.
Yeah.
We did make an adjustment
Right.
to the language that we thought might work, but then it seemed like they weren't convinced.
And the language that we originally adopted was to say, in effect, that a con would not be required. Is that correct? A
Or-
con exemption.
Essentially, they felt that we would be allowing an ambulatory surgical facility to be established without a CON, and
Right.
that was not permissible.
That was not permissible. Let me ask you this. I find all this kind of curious as a political scientist, but the issue here seems to me is that is the commission, and this is, I guess, a fundamental question in a way, maybe Sue Ellen can help us, but is the commission bound by the legal determination of another, of a staff of another agency or administrative body? I mean, the reason I bring this up strikes me that, there's such a thing as staff-driven, but this sort of gives a new meaning to the word chutzpah if, in fact, we're going to be, making determinations about the legality of our regulations based on what one group of staffers said to another. I just find that whole thing troubling. They may be right, but I think, given the gravity of the kind of thing we're talking about, I think maybe an attorney general's response would be appropriate.
Okay. If the staff says that something does not comport with statute, then the step that we didn't get into, because we were talking about changing it, is there's a letter that comes from AELR that says we don't think this comports with statute, and come down here for a hearing. Okay. And so that's what would have happened if it had gone to the next step. We had, I guess, sort of interim language that they seemed, that they indicated might be acceptable. But because of Senate Bill 707 that provides that HSCRC can, under its regulations that it had to adopt, give rates for outpatient services at an FMF, which in HSCRC's parlance means on the campus of, just like at a hospital means on the campus of a hospital. But there's a provision in the law, I think it's like Health General 19.3 B02, but I wouldn't swear to it. That says that. Yeah, I shouldn't have said it. Okay, I shouldn't have said it. It says that.
You're not under oath.
Okay, yeah, good. But says that HSCRC can't give rates for a freestanding ambulatory surgical facility. So that there has to. It's not just really what the staff to AELR or Legislative Services or a committee in Annapolis said. It's the two items that need to be addressed specifically so that HSCRC, if they thought it was appropriate, could consider an ASF at a freestanding medical facility to be for rates at an FMS. But it's not just what the staff said, it's more.
Okay. Thank you.
Thanks for that clarification. Jerry, one last.
I just wonder why we would even equate an FMS in a city hospital replacement or otherwise to a rural hospital replacement. I think they're entirely two different things, and that's why ARMS is asking for all these changes. And it'll be discussed down the road, I'm sure, when it comes up about access and quality to care and so forth. And I just think we're creating an entirely new entity. I think we're extending the definition FMF beyond what its intent was. Now adding ambulatory surgery centers, and the semantics, it gets confusing. It's not a self-standing ambulatory center, it's an ambulatory surgery center, and then there's freestanding. They're both regulated spaces. Ambulatory surgery will not be regulated, or
It's regulated.
be regulated?
Well, okay, are you talking about rates, or you mean like licensing?
Rates, yeah.
It would be up to HSCRC.
We don't know yet.
I think they want to have the authority to decide on a case-by-case basis if they want to give rates for that particular FMS to have surgical services on that campus.
I just think we're very subtly giving birth to an entirely new entity beyond its initial definition.
questions? If not, let's move to a vote. All in favor of adopting Cohort 10.419, say aye.
Aye.
Any opposed? Opposed? Diane? Barry? Any abstentions? And Commissioner on the phone, to identify yourself. Commissioner Metz, is that you on the phone?
Yes, it is. Thank you.
I just want to get your vote. Thanks. Okay. Motion carries. Move to agenda item number 4, which is a certificate of need for Calvert Memorial Hospital. They have applied for a CON to construct a 3-story addition to increase the number of private patient rooms and create an observation unit. Kevin McDonald will present the staff recommendation. Kevin?
Thank you. This project bears many similarities to the suburban hospital project that the Commission approved this summer. Like that one, it is essentially a modernization of an aging physical plant to create space that can support today's practices and standards of care. Calvert is currently licensed for 76 acute beds and 18 comprehensive care beds. It has 87 patient rooms with 120 physical bed capacity. Post-project, it will have 100 patient rooms with, again, 120 bed physical capacity. Operationally, the hospital intends to operate all of its medical surgical beds as private rooms. The primary focus of this project is creating all private rooms and a dedicated observation unit. The project will build 2 new 20-bed medical surgical nursing units, convert a 20-room, 31-bed nursing unit into a dedicated observation unit with 18 beds, and convert 7 patient rooms that currently hold 9 beds to alternative uses, including relocating an inpatient dialysis unit, office space, staff support space, and ancillary services. Cost of the project is projected cost $51.6 million, and except for a projected $5 million in philanthropy, Calvert would be funding the project entirely with cash. They also are not seeking an increase in GBR to cover project-related costs. The staff analysis of the key standards and criteria is as follows. Looking at need and capacity, modernization is the primary driver of need for this project. Again, private rooms and observation beds. The project fits within the MHCC projected bed need for Calvert County, and the hospital's MSGA physical capacity will not increase because the renovations and repurposing of patient rooms and the hospital's intent to operate all of its medical surgical beds as private, the operational bed capacity would actually decrease. Looking at the project from a cost effectiveness standpoint, the hospital described several alternatives it considered, and this proposal combining new construction and renovation seems a logical approach to achieving their stated objectives. Looking at the financial feasibility and viability, it's proposed to be funded with cash and philanthropy. The hospital's audited financials demonstrated Calvert's financial wherewithal to fund this project, and its financial projections show positive ongoing financial performance after the project as well. They're not requesting a revenue budget adjustment for the increase in capital costs associated with the project, and both MHCC and HSCRC staff concluded that the assumptions underlying the financial projections are reasonable. The estimated construction cost does exceed the Marshall Valuation System benchmark by 3.4%. So although the hospital stated that it will not request a rate adjustment to cover capital costs associated with the project, the reason they are here seeking a CON is to reserve the possibility of doing that in the future should they need to. Otherwise, they could have taken the pledge and avoided a CON entirely. So that necessitates attaching a condition to an approved CON that any future change to the financing of this project involving adjustments in rates set by HSCRC must exclude approximately $2 million from any rate increase. Looking at the impact on other providers and the health system, Calvert is the only hospital in the jurisdiction. It's not proposing any new services, and no impact is expected on other providers. They also do not anticipate any increases in patient charges directly related to or associated with the project. And moving to all private rooms should make the hospital safer and better aligned with contemporary patient expectations, as well as enhance the efficiency of the operation. Staff analysis is that the relevant SHP standards have been met, as have the criteria in COMAR 102401. Thus, staff recommends approval with two conditions outlined in the staff report and recommendation related to restricting the use of MSGA nursing units to one patient per room unless getting MHCC approval otherwise, and excluding $2,017,244, which was calculated as excess construction costs from any future funding request that may be made to HSCRC. We do have several folks representing Calvert here. Dean Teague, the president and CEO. Monty Suter, who is the owner's rep. Keisha Sweeney, Associate Vice President of Corporate Communication and Client Service. Richard Coughlin, who is a consultant, and Jack Eller, their counsel.
Terrific. Can I get a motion to approve the CON for Calvert? Move. Second. And any discussion or questions?
This is Commissioner Hasty. I'm going to recuse myself from this decision.
Okay, thanks, Commissioner. That's noted.
Thank you.
I was just hoping you could speak a little bit more to the notion when you were talking about the cost effectiveness of this particular project. And you mentioned that they had done the analysis and that staff agreed with the assumptions. Did staff do any further kind of parallel analysis to second opinion?
HSCRC is basically a second opinion for us on that. The assumptions were very close to this project does not project great changes at all, and in fact it does project decreased utilization as they are endeavoring to get out potentially avoidable utilization. So any growth related to population increase is in many ways offset by their avoidable utilization. So we thought the assumptions were pretty sound and didn't really ask for or run alternative scenarios.
Okay, thank you.
Questions here. Do we believe that the Marshall Evaluation Service benchmarks are appropriate here?
Are they appropriate in terms of use or?
Just as a benchmark, because some of the language in the analysis sort of hedged on that issue.
I think I would ask my associate, Joel Ricklin, who is more versed in that system to help with that answer.
I think you said you thought that some of it was set to catch them. Is that what the word was?
No, I'm just asking a simple question. Do we think it's the appropriate benchmark?
Oh, yeah. I think it's,
Right, this is part A. So
Yeah.
then part B
I
is if they exceeded the benchmark, can you just sort of summarize the reasons why that they've exceeded the benchmark? Any sense?
not really.
Okay, so maybe ask them. Any? I just don't know. Sometimes when we talked about cost, there have been like clear factors why there might be a cost overrun or something. So it's just literally just a simple question of why in this case it would have exceeded that. Yeah, this is my.
Sorry. We submitted, I'm sorry, I'm Dean Teague, the president and CEO of Calvin Memorial Hospital, and I thank you for having us here today. We submitted the CON on October 29th of 2015. We had actually been working on the CON for about a year. What we understand is that the standards have changed on the Marshall, correct me if I'm wrong, that they got a little bit more stricter or tighter than what we originally had submitted. There's no tremendous cost overruns that we can find. We were a little surprised by it, but we're willing to accept it.
Okay. All right, so the benchmark thing. Okay.
The benchmark does change with time, but there weren't any really significant changes. So I'm not sure exactly. Well, if anything, the benchmark tends to move up over time.
We'll accept that.
But there is some differences of opinion and some estimates, and I'm not sure exactly why. I mean, differences between, they thought certain things should not be included in the comparison. For the most part, we agreed with them, but I think there were a few situations there we didn't.
Okay. All right. Other questions?
The CON was submitted in October 2015.
Yes, sir.
And you were in the planning stages of that for a year before that, so approximately October 2014. It's now November 2016, so we're 2 years later down the road.
Well, we chose not. We probably could have submitted it in April of 15, but we were in the process of changing the CEO. My predecessor, Jim Zinnes, had retired in March, and we felt that it was probably better to wait until the October time for him to submit it.
I'm just trying to get a sense of how long between the time when you've done your internal analysis, you decide you want to go ahead with a project like this, and the time that it actually gets done based on going through this CON process. It doesn't seem like it added a whole lot to the whole equation here, except a bunch of costs to how much it costs to do this project. So it's about an 18-month delay is what you're thinking that this whole fiasco costs?
No, we could probably go back before that, because the reason that we're paying this in cash is that Jim made a wonderful decision to actually sell a medical office building, so we'd have the cash to do this project. So this has been basically on a strategic plan for about 3 years, but the commission has been pushing everything through as fast as we possibly could. There's a lot of planning that has to happen in the facility itself. There's a lot of pieces where you have to figure out, for example, the front door of the hospital for the next 3 years will be in the emergency room instead of the front door. So we were trying to get ahead of some of that stuff while this was all going on at the same time. It has cost money, but I would not put it on the commission at all.
Thank you. Fran, and then Diane.
Thank you, Mr. Chair, and thank you all, the representatives from Calvert. I know from experience of a number of the very innovative projects that you've taken on with your local health department in connection with behavioral health and infant mortality reduction, and it's been really an innovative project.
Thank you.
My question really is for Kevin. Okay, so my kudos to you all for the work that you've done. Kevin, you said something quickly, and it's a fundamental question that I have about CON or no CON with regard to this particular application. So there's no increase in bed size, there's no change in service lines, there's no financing, and in fact there is the intention not to go back to a rate adjustment that's for the cost of this construction. And then you said something very quickly. If they had taken the pledge, they wouldn't have had to do a CON at all, but I'm presuming they didn't take the pledge, and so here we are. So could you explain that a little bit?
Yes, that's probably a term you haven't heard that frequently, so I apologize.
We've heard the term.
Yes, yes.
There is a provision in regulation that if a proposed project is not going to be seeking a rate increase more than $1.5 million, and otherwise doesn't do anything that would be categorically reviewable, such as add beds or add new services or add ORs. If a project fits all of those, checks all those boxes, they do have the option to essentially request an exemption, and we would review that. HSCRC would review that. We would review it basically to determine whether there are any factors that would categorically require review. HSCRC reviews it more from a perspective of they're not going to be asking for a rate increase. Can they actually afford that? Do they actually have the assets and the wherewithal going forward to afford to do that? And so in this case, they probably could have taken the pledge and avoided the CON, but by going through the CON process, they do reserve the ability in the future, should their estimate be wrong about their need for a rate increase related to the project, it does reserve the right for them to go back and do that.
So simply put, it's their intention now, your intention now, not to do that. But if something changes in the future, by going through this process, that leaves the door open for you to go back and to seek some kind of adjustment in the rate.
Yes, we had a long discussion with our board of directors about this. I call it buying a piece of insurance. I'm not really sure how you want to put it, but it's fiscally sound for us to do it this way. It did cost us more money than we expected as far as doing a CON versus not doing one.
Just ballpark, can you just...
I don't have a clue at this particular point. I don't know. I'll be throwing a number out, and I'm not a lawyer. My lawyer back there is telling don't throw a number out.
Okay.
I could probably get a number for
like
it.
a range.
Let's put it this way: it was more than 100,000, but it's probably less than 500,000.
Okay, the range. Yeah. Ben, can you just give a context about the historical use of the pledge and what's happening now to build on that?
So, I think given the transition to the global payment model, that even, as Mr. Teague said, those that are inclined to maybe consider taking the pledge, given the level of uncertainty, are going through this process because it does leave open avenues for additional rate adjustments that people feel aren't needed, but want to protect themselves given changes in the global budget methodology going forward. As most of you know, we're in version 1. Version 2 is being submitted at the end of the year, and although there's a good deal of uncertainty, that will roll in 2019, supposedly. Historically, I think we'd probably want to get back to you and say, of the projects of this size, in the past, how many have taken the pledge? I wouldn't have that off the top of my head, but I'm not surprised given the transformations in the healthcare system that people are trying to use as many options, keep them open as much as possible. I don't know if Mr. Teague has any reaction to that, but I think you want flexibility right now.
Yes, I would agree with you. I think that for our perspective, we've been on TPR for the last 6 years, and then in July we were put on GBR. We're still trying to figure out what that means as our hospital continues to evolve. We have a very strong quality and safety record, and for us, it's just we want to make sure that at the end of the day we don't waste taxpayers' money if we don't need the rate increase, which right now we don't. But we want to make sure that if 3 or 4 years from now we don't continue to get sufficient rate increases because of the money being drawn down, the changes in politics, all these other pieces, that we've got that ability to come back to say, we're having a tough time here. We need to get some money in our rates so that we can continue to run the operation.
Thanks. Let me go to Diane.
So I'm asking to get a bit of clarity as various dates were thrown around in terms of when the application was submitted, and this is now mid-November. So you said the application originally was submitted in October of 2015, so about a year ago?
On my birthday, October 29th, 2015.
Okay, so about a year ago.
Yes.
I just know that I beg to differ with the use of the phrase fiasco, but the process in terms of the review of the application was a year.
Yeah, I will tell you that it's been very cooperative all the way along. If we had questions, we were able to call Kevin and his staff. They responded back to us right away. We certainly knew there were going to be issues because of the other hospitals that had CONs in front of us. And when Prince George's got thrown in the mix, Kevin was very good about calling, asking us and just be a little bit more patient because of what's going on. and they've been very good to us.
Perfect. John? No? Bob?
No, I think the issue here, first of all, for the record, this commission would like to see specifically the cost of this process to Calvert.
Okay.
All right. Now, you mentioned $100,000. Frankly, given all the struggles we're having right now in healthcare costs and trying to do everything we possibly can to get value for the healthcare dollars, that $100,000 is a big administrative cost.
Yes, sir.
It sure is.
Yes.
And this commission generally is somewhat concerned about the fact that we have such a heavy regulatory system in this state that it is imposing costs on providers that ultimately affect households. It is not hospitals, it is not employers, it's not doctors who bear the health care costs. 100% of all health care costs are borne ultimately by households. This commission and members of this commission are very concerned about this. So that figure is vitally important, I think, to us. And we've got to start looking at this very closely because going forward, there's going to be a lot of demands. We are in a period of tremendous change in the healthcare system. And what we want to try to do is get value for the money. And sometimes that value is subtracted by an excessive regulation on doctors, hospitals, clinics, home health agencies, and various other institutions. So that's why, maybe the word fiasco is not the best word to use, but nevertheless, the fundamental truth here is that we have got to do something to streamline a lot of what we do. And that's why the information that we're asking you for is critical.
Please understand, I'm not trying to hold back on the information. I don't have the number and would like to get that.
Just follow up.
Not the issue. I'll get it to Mr. Steffen. Thanks, man.
Just to put this in a little context, people come in front of us all the time, and we haven't, we just see the final product.
Right.
So all we're saying really is it would be nice to know if a hospital comes forward or a nurse, what is both the time and the money involved.
Okay.
It doesn't mean it's not good value. That doesn't mean it's too much, too little, whatever. It just means a body like this should be aware of what they're asking people to do, so that they don't do it lightly. Thank you.
Thank you.
Great. Yes.
Not specifically related to this, but what happens if somebody takes a pledge and runs into financial difficulty? Do we then say, sorry, you took the pledge?
I haven't seen that, and that's more a question for HSCRC than for us, I think.
Hopefully commitments are commitments. All right, let's move to a vote. All in favor of approving the CON? Say aye. Any opposed?
Aye.
Okay, got that aye. Any opposed? And then there was one abstention. Okay. You have your CON. Thank you very much.
Thank you. Kevin, thank you very much. Appreciate it.
Take care. Thanks. Move to the next CON, which is the Kaiser Permanente South Baltimore Medical Center, which has applied for a modification to its previously approved CON due to increased project costs. Kevin will present the recommendation. Kevin?
Okay, this CON was originally approved in June of this year, and it is to finish shelled OR, a third, which would bring the facility up to 3 operating rooms. The original cost was $1.6 million, which Kaiser Permanente planned to fund with cash reserves. Kaiser soon realized that the project cost was underestimated, and they filed for a project change after approval. The cost increase is about $650,000, approximately 40% over the original estimate, and well above what is the permissible inflationary allowance in the regulations. Kaiser still plans to pay for the project using cash reserves. The projected cost increase is essentially due to original estimates that were incomplete and incorrect, and those mistakes are described in the staff report. Despite the cost increase, staff's recommendation is that the initial commission findings regarding the project remain valid. The project complies with all applicable state health plan standards. It's needed. In fact, the current usage would more than justify a third OR. it's a cost-effective approach in meeting Kaiser's objectives. It's financially viable, proposed by an applicant that has complied with the terms and conditions of previously issued CONs, will have a positive effect on Kaiser's ability to provide outpatient surgery to its members without adversely affecting costs and charges to them or to other providers of surgical services. Although theoretically there would be a cost increase to subscribers' premiums in the scheme of things and the size of the organization, it would be very, very minimal. So staff is recommending that this modification be approved. Again, we do have several representatives from the applicant here. We have Mike Bellamy, who's the Director of Facility Services, Brett Cass, the Construction Manager, Josh Weiner, Consultant for Delivery System Planning, and Andy Solberg, who is their consultant, CON consultant.
Okay. Can I get a motion to approve the CON modification? Okay. Okay. John, your refusal is noted. Any questions or comments? Sure.
This is kind of disheartening. This is a very short time period to come back with a 40% increase. Why would we have any confidence in the current set of estimates, given this pretty shaky track record to date?
I think that's a question for the applicant. Well, I can tell you that when staff initially looked at the first estimate, it actually, first of all, MBS is a very difficult standard to look at for that kind of a facility. But it did look like it was fitting within what we would have expected. So we had really no reason initially to suspect that there was an underestimate in cost. Now, this is a relatively small project, and I think these OR projects can be very variable. But again, the original estimate did not seem out of line according to the best MVS analysis we could do. As far as going forward, as far as future, we staff did ask kind of similar questions, because some of those reasons for the underestimates seem fairly elementary. So we kind of satisfied ourselves with asking those kind of hard questions, and they did acknowledge the mistakes, perhaps that they came in too quickly, too prematurely with the estimates and the application. Beyond that, I guess I'd invite someone from the organization to.
Well, let me just ask a follow-up before you do that. So what is the guarantee that it won't be revised again, upward again? Is this time for the pledge?
Well, the pledge could not be used in this case because it is adding an OR. So that would be categorically required to have a CON.
Let's ask Kaiser to respond.
Yes, good afternoon, Mike Bellamy. Just to address your question specifically in terms of our confidence in this number, the number that we have now is actually based on actual bids that we went out to the market, and that's really what drove the cost. All of the bids that came in exceeded our estimate, and so that's why we had to come back. So the contractor is prepared to sign the contract for the amount that he's estimated for, pending the receipt of this modification. So we're very confident in the number that it won't adjust.
Follow?
Yes, and so in terms of your contractual agreement, is there, what are the provisions for a cost overrun? Is it basically back on the contractor? We, of course, are just interested in how this ends up in a per member per month and back on the taxpayers, back on your subscribers, and what it does to overall kind of, changing the, I mean, you said it was cost effective for the organization. I'm kind of wondering how cost effective it is for your premium payers. But so is there some guarantee that if there is a cost overrun at this point, it goes back on the contractor and it's not going to come back and be reflected in premiums down the line?
Yes, I think within our standard budget structure, we have a contingency allowance for unforeseen conditions, which is probably something that we might encounter in a situation like this. But again, based on our bid results that we get, we're fairly confident that this number is not going to go up.
Got it.
And Kevin, just to clarify, how often does that happen when we get the estimates that people haven't gone out to bid? Is that usual procedure?
I think in most cases they haven't gone out to bid.
Okay. Clarify. Other questions? If not, let's go move to.
So Mr. Flagg's making me nervous, so I'll recuse myself as well.
Okay. 2 recusals noted. All in favor to approve the CON? Aye.
Aye.
Opposed? Abstention. Okay. You have your CON.
Okay, thank you very much.
Is there some way, Kevin, just to think about in the future, about the idea of how we want to time these things? Just to avoid this sort of situation. Does it just make sense that you move forward on a CON before you actually know what the bids are going to be? Is there some way we could flip that, or is that going to extend the CON process even longer? Or it would bring us in a little later in the process after the bids were already fielded.
I think it would probably commit an applicant to spending more money up front before they knew whether they had a CON to do that.
Got it. So it's a little riskier for the applicant. They might spend the money to run a bid, and then with this big question mark about
their architectural work would have to be further advanced than it often is when they come in with the application.
Okay.
Which has a cost.
Okay. So, but the rub here is the ability to properly predict, just model for whoever, what it's actually going to cost when it hits the market. And is there anything we can do to help? Is there data? Is there some way to improve the methodology to help potential applicants know what they really will face in the market?
I can think.
You can say no. I mean, that's fair enough.
I don't really think there is. I think that's. I worked probably 18 years on the hospital side, oftentimes involved with facility planning, and I think it really is the responsibility of the applicant to do that.
Okay.
To work to find a good planner, a good architect, and a good cost estimator. You need all three. You need all three of those, and that's really the best way to do it.
Thank you very much. Move on to the next agenda item, which is the MCDB Data Submission Manual. The 2017 manual is designed to provide designated reporting entities with guidelines for technical specifications, layouts, and definitions necessary for filing the reports required under COMAR 101506. Ken Yates-Trotman will present updates to the manual, and he'll also provide a brief update on the work with other APCD states in developing a common data report format for ERISA protected health plans. Ken?
Good afternoon, Commissioners. A quick overview of what we will go through this presentation. I'm sorry. Right. A quick overview of what we will present in this presentation. We will give a refresher of the MCDB reporting requirements, also review the changes in the submission manual, give a quick update of the COUCH's the Supreme Court ruling, how it impacts the MCDB, and the seeking approval of the submission manual. What is included in the MCDB? From a commercial entity reporting standpoint, we include life health insurance carriers and HMOs, TPAs, PBMs, the behavioral health administrators, qualified health plans, and qualified dental plans. The type of data that is included in MCDB is the eligibility information, claims file information in terms of professional services, institutional pharmacy, and dental services. You also have the provider directory that the payers populate, and in the future we will be collecting a non-fee-for-service spending. And the MCDB also includes Medicaid MCO data, and that is provided by Medicaid via the Hilltop Institute. Medicare information is also acquired by from CMS. What is changing in the MCDB? No changes in Maryland reporting requirements, except for reporting of privately insured ERISA self-funded health plans. Maryland will not be enforcing data collections from privately insured ERISA self-funded health plans, which is largely, mostly the large employer group, due to the Gobert versus Liberty Mutual Supreme Court ruling March 1 of this year. The MCDB versus MIA data reconciliation have been brought into the submission manual as an additional requirement by payers. Payers will now be required to reconcile membership, allowed claims with the actual memorandum data sent to the MIA via rate filings before submitting data to the MCDB. This reconciliation process only applies to ACA-compliant health insurance plans sold on and off the Maryland Health Benefits Exchange. We also have two additional fields. This is not new to the MCDB, but new to certain files in the MCDB. For the professional services, for the pharmacy services file, we added the allowed amount field. And for the professional services, pharmacy, and dental services file, we added the amount paid by other insurance. As always, to promote timeliness for payers to submit data to the MCDB, we are doing this through clarifying reporting requirements and validation checks, shortening submission and review timelines, and enforcing our finding authority for payers who think seriously delinquent in their submission. Now we look at how the Supreme Court ruling has impacted the MCDB. Before the ruling, we had 3.7 million covered lives for both Maryland and non-Maryland residents that are under the under Maryland contracts. We had about a 60 to 40 split between self-funded and fully insured. To estimate the Gobert ruling, the Supreme Court ruling on the MCDB, we used the 2014 data, and we determined that about a third of the MCDB would be lost due to the ruling. It's 34%. What are the impacts on certain use cases for public reporting and transparency initiatives? Things like the industrial portal have a low impact. Consumer portal have a low to medium impact. For performance reporting, network for regional health initiative improvement, total cost of care have a medium to high impact. For healthcare reform, it's a CRC, hospital payment model have a medium impact. For the MIA rate review, there is no impact because only fully insured data is used. Policy reports and annual reports and legislative reports have a low impact. As a update on this court ruling, this was between the state of Vermont, APCD, and Gobain versus Liberty Mutual case. Liberty Mutual, acting as an employer contested the government ruling that their TPA, which was a local blue plan, must submit data to the ABCD. This went all the way to the Supreme Court, and the Supreme Court determined that government's requirement was preemption of the Employee Retirement Income Security Act, or ERISA, for privately insured self-funded health plans. This decision affected about 16 states with ABCD, including Maryland. What was done since the ruling in order to get access to the data that was lost? The Department of Labor has the statutory authority to require self-funded plans to submit healthcare claims and related data under the Public Health Service Act, which is incorporated into ERISA and applied to group health plans by ERISA. The goal of the ABCD states is to encourage the DOL to revise the ERISA self-funded group health plan reporting requirements to include membership and claims level data consistent with ABCD reporting. MHCC staff is collaborating with the ABCD Council, the National Academy for State Health Policy, the National Association of Health Data Organizations, and other ABCD states to develop a comprehensive plan in the form of a common data layout that the DOL will implement through a federal rulemaking process. NAHCP and others have submitted comments to the DOL on behalf of ABCD states, including Maryland, on proposed changes to Form 5500 annual report for employee benefit plans, including the new Schedule J that will tie to the common data layout. MHCC staff has also submitted comments to DOL endorsing what NAHCP and others have suggested. The next step is to get questions from the Commission and ask for your vote in posting the submission manual to the Commission's website, and also disseminate the manual to payers and with follow-up meetings, and implement these changes for submission starting in May 2017, which is the first quarter of 2017.
Thank you very much. Can I get a motion to approve the release of the data submission manual? Any questions or comments?
I had a question about the proposed amendment to Form 5500. How is that supposed to work? The employer files Form 5500 and the attachment is all of the medical claims for their plan for the year?
The Form 5500, that is something I don't have an answer for. I will have to research, but the 5500 is basically a report which different government agencies use to assess benefit plans and economic trends. So, but in terms of the MCDB getting the information back, is that the Schedule J will be a source to supply the data for the 5500.
So I guess that was my question. If I read this right, the Form 5500 is an annual report that every self-insured plan makes to the federal government, and includes things like the compensation that you pay to the various fiduciaries that administer your plan. So this would have an attachment whereby every self-insured plan in the country would give every claim that they paid, including the PHI on the claim, to the federal government on an annual basis, so that it can then distribute it back out to the state. I just wanted to, that's what it looked like. I just wanted to, if I was wrong.
Well, the DOL will have to decide how that is going to work. We have no say in 5500.
Oh no, I'm just asking what you think the LO is doing, if I'm right.
Turn on your microphone, please.
They have basically a couple of options. One is it all flows to DOL, which we think is unlikely. And instead, they would say to the carriers, then you submit this data to the appropriate state agencies. I think that it could be submitted directly to the states versus them collecting and disseminating.
Right, because the DOL will hopefully, we don't know it yet because those are in the comments, but hopefully they are going to designate the state to be the recipient of the data that will be reported through the Schedule J.
So you file one part with one agency and another part with another agency. Okay, thank you.
Yeah, it's been a good decade since I worked with 5,500 data. But you're right that it's more a notion of the Department of Labor's responsibilities to make sure that this is a real plan. And it's, often you see most 55, it's analysis of pension plans and it's the 401k adequate, et cetera, et cetera. So it would be quite a stretch for them to move to something that is, submit your 50-page form plus download 1 million records or whatever. So, it will be interesting to see. I would also think and we have employers here, that the notion that they would sort it out by state may be a little optimistic. That if you are, they'll probably scramble the IDs and send everything and let the feds divvy it up and figure out who to send it to. The other thing is that I was just going to say is that to a certain degree we should not kind of put our eggs in all if this was 2 years ago and there hadn't been an election, to think of the Obama administration, Department of Labor, they probably should have done this a long time ago if they thought it was a good idea. Now this amount of increased federal regulatory profile may be less likely. So I guess I would only encourage that if we would like this data and we would like it to happen, that a more kind of a conversation with the major employers in the state about a voluntary or at least some sort of being sure that there's something that there might be a middle ground to approach each other about might be, it doesn't solve the national problem, but I was concerned, if you're losing a third of your records and it's not the exact same population as the 2/3 you have, it will make life difficult for anybody trying to develop policy in the state of Maryland. But
we have sort of looked at the large employers, like the state of Maryland, which is a government employer and is not ERISA exempt, versus the private large employers, and in terms of patterns, and they're very similar. They tend to be more generous. They tend to have lower deductibles in the large employers. So I think we're kind of monitoring that as a proxy.
Well, that makes sense. And then so would you kind of impute, kind of using the state as to sort of fill in the because we're not going to assume they're like the Medicaid population or the Medicare population or other populations we would have. So you state employees as your proxy, and then effectively you kind of reweight your data to say, Ben doesn't represent one person, he represents 2.5 to make up for the private sector Ben equivalents. Okay, thanks.
So a couple of things. Appreciate the update. This is very important, obviously, for the work that we're doing, and an update about what's happening at the federal level with the various states coming together is very helpful, although it's completely out of our control in terms of what the Department of Labor does or what happens at the federal level. However, there is information from this that can be very helpful, and that is the consistent structure of the data submission, because we know that employers don't want to deal with a patchwork quilt of different expectations state to state. So focusing on what we can control, anything we might do to engage with the employers, if we can use that the common data layout, so we're already setting ourselves up to take a consistent approach with what other states are doing, that would be helpful. The other thing I would mention, one of the projects that I'm working on in my work is with the state of Minnesota, where we are working with the employer community to see what we might do in terms of designing products using a public use file or the information out of the all-payer claims database, the Minnesota all-payer claims see what might be of value for self-insured employers that would potentially motivate them to choose to submit their data to the state in order to get these reports that would be designed by the employers. So this is a project that's going to be happening next year. I know Washington State is going through a similar process. So even if we don't have the money within this commission to go through that kind of process, I think there's some good information that will be coming out of the Pacific Northwest and also in Minnesota that we could potentially model some data products that could be of value to self-insured employers to be willing to submit. And I'm happy to share with you because I'll be working closely with Minnesota on the project.
Other questions or comments? If not, let's,
Really quick question. Some of the work that I did about 5 years ago, I'm looking at the aggregate health status of state employees and their desperate need at that time for a wellness program and other kinds of enhancements. Suggested to me that the health status of that group and their utilization was really quite different than that of a comparably sized employee group. So did I misunderstand that you were going to extrapolate this 1/3 missing data with using the utilization of the state group, state employees? Or no?
Well, what we're going to do, we are going to use.
So what I would say is the fully insured product, fully insured employers who tend to be smaller, they're very different. But once you start to talk about larger employers,
right.
then they tend to be more generous in their benefit plans. They tend to have lower deductibles. Maryland actually has one of the lowest deductibles among employers in the nation. There was just a report that came out. Lowest deductible level. But high payments because they're generous. And yes, they when the population is a little older, then they tend to be a little sicker. But we could probably make an adjustment for some of that risk if we saw if we looked at the risk adjustment between the two. But just based on a per cap PMPM payment per month, they're far more similar. Large employers, regardless of whether it's a government employer like the state or teachers, than the fully insured products, which are much more restricted. But we've been doing that for HSCRC, so we found them to be very similar. And actually, in a couple of weeks, we have a meeting with them to look at that data again.
Drill down on the risk adjustment factor, because the plan designs you can account for, but the underlying morbidity in the population.
Yeah.
Okay.
But it's also not just the state. You have the county government, unions, things like that, right?
Mm-hmm.
And also the federal government, the federal employees.
All of those people, right? They're all in the not exempt.
Yeah, if I was a betting person, I would think that the state government utilization patterns would be a lot different than other large ERISA pieces. I mean, it'll be interesting what the data says, but I'm bet on the opposite. Yeah.
At the federal level, when we were developed for the Part D drug benefit, we used federal employees as a proxy for along those lines. And the one thing to just keep in mind is it's a truncated income distribution. So, you don't really have a large poverty, there aren't a lot of civil servants below the poverty line, and there aren't a lot of millionaire civil servants. So you're crunch, so that when you're looking at things like cost sharing, effects of those sorts of things, that's going to be on a little thinner ice than if you think about just simply, do they prefer HMOs versus PPOs or some of those other sort of behavioral changes. But it'll be interesting to see. It would be interesting if you have an ability to benchmark, and you may want to, there's some of the stuff like the private sector. I'm thinking of some of the large collections of what benefits are offered. I'm blanking on the name of it's a Truven database. It's expensive to use, but at least to benchmark how well this comes up, to know really, in the state of Maryland, whatever, dental is a little more generous in the private sector than it is in the state government, or whatever those differences might be.
You're searching for markets again.
I am searching for markets again. Thank you very much.
We have some experience with that as well.
Yeah, not good, but.
Can I get let's call for a vote for approval for release of the data submission manual. All in favor? Aye. Any opposed?
Aye.
Any abstentions? Approved. Our next item is the Maryland Physician Services Trauma Fund. So in 2003, the General Assembly enacted a legislation creating the Trauma Fund to aid Maryland's trauma system by reimbursing trauma physicians for uncompensated care losses and by raising Medicaid payments to 100% of the Medicare rate when a Medicaid patient receives trauma care at a designated center. Last year, the Commission voted to raise Medicaid payments for trauma care to 105% of the Medicare rate beginning in fiscal year 2017. And Bridget and Karen will present the report.
Good afternoon, Mr. Chairman and Commissioners. The Maryland Healthcare Commission, along with the Cost Review Commission, is required to report on the status of the Trauma Physician Services Fund annually to the General Assembly. Therefore, we are here. As a reminder, the Trauma Fund reimburses physicians for care provided to uninsured patients at trauma centers. We also offset trauma centers' costs for providing on-call services at those trauma centers, and we provide grants for trauma-related equipment to the trauma centers. This past fiscal year, the fund received $12.3 million from MVA and expended approximately $1.6 million in uncompensated care, $7.5 million in on-call and standby, $57,000 to Medicaid, $161,000 in administrative expenses. That would include staff costs, audit costs, TPA costs.
The 8% reduction in payments that was put into effect July 1st, 2009, ended at the beginning of fiscal year 2016, when the funding was restored to 100% of the Medicare rate. Both uncompensated care and refunds to the fund were substantially reduced during FY 2016. The Commission staff expects that similar results will happen again for 2017. Uncompensated care payments and on-call stipends were increased by 5% above the Medicare rate for fiscal year 2017. I'd like to see just a few of the highlights that are in the report. I would like to add that the surplus in the trauma fund right now is $7.5 million. We're not making any or proposing any recommendations in the report right now to spend down that surplus. This decision was made because there's been issues identified relating to the reimbursement rate for MCOs and FFS by Medicaid. Medicaid is currently working on a resolve for these issues. Therefore, we would like to wait to see what the financial implications will be to the fund when that's resolved. Because our statute allows us to adjust the reimbursement rates at any time, providing that we give 60 days notice to both Senate Finance and HCO committees. We suggest that once these issues are resolved and the impact to the fund is realized, that we bring back to the Commission some recommendations when a spend down plan of that surplus. However, since the annual report is due to the legislature on December 1st, we would like to proceed with requesting your approval to release the report to the legislature with a plan to update or make recommendations to the Commission in the early spring. This concludes our presentation, and we're happy to answer any questions that you might have.
All right. Can I get a motion to approve the release before we have motion? Second? Okay, let's have discussion.
So we've had substantial comment around the challenges in figuring out what the appropriate levels of the fund are and what the appropriate levels of reimbursement are. And right now, it's easiest to say, the best way to describe it is something's very broken. The providers are getting paid overall. The collection rate overall for the uninsured and Medicaid population has dropped precipitously in the past couple of years. And there are at least several several explanations for it. One is a change in the site of service calculation for payment. One is a change in the multiple procedure reduction calculation. And the third relates to the inability of Medicaid and the HMOs to get the rate structure correct in their computer systems. And all of that leads to the answer that right now we have no idea what that $7.5 million surplus means. It may mean that we have more money than we need in the fund, and it may mean that we don't even have close to enough money in the fund. But layered on top of that is the complexity of what happened a couple of weeks ago in the election, and what that may mean for the Affordable Care Act and what that may mean to the uninsured rosters again, which would transition the responsibility for care away from the MCOs and Medicaid back to an uninsured pool potentially, which would actually wind up being much better for providers. And in this particular case, that's not a blanket statement about everything, but it's certainly in this particular case, it was much better for providers, and which would change the obligation of funds. So it's a very long-winded way of saying I completely support the report and the conclusions in it.
Thank you. Other questions or comments? Diane, Fran?
Just a quick question. Notice that the administrative expenses went really, dropped quite a bit. Why?
I think it's 2015. The commission had never billed the fund for our labor costs and what it costs for Karen to do it full time, needs to review it, Brian to financially send everything to general account. So we actually went back and billed the fund for a few years.
3 years.
3 years.
All at once.
So now you're seeing the decline because we only do it year by year.
So the 160,000 or so is for 1 year.
Correct.
Thank you.
Thank you, and thank you both for this report. It was great. Two more questions on that page, on page 7, the other graph comparing the expenditures FY 15 and 16. So the precipitous drop in the uncompensated care payments is because of greater levels of insurance, right? That's pretty straightforward. What about the drop in the credit recovery? Is that the subrogation?
Directly related to the number of claims we pay.
Oh.
Those,
wait a minute now. So
the recoveries come from physician
right.
offices when they find out that they've billed the fund for a claim for which they then receive reimbursement from somewhere else. This is a fund of last resort, so they have to repay it.
Okay. So it's not third-party liability. That's not the recoveries that we were getting. Right. Okay, I get it.
Just correct me, because as a new commissioner still, so the commission decided to pay more than the Medicare rate?
Yeah.
But if I'm hearing you right, Dr. Pollack, that's sort of an odd, doesn't fit into the categories of if you're talking in terms of billing operations. It's not quite the same as the Medicaid. It's not the Medicare. It's sort of its own unique bucket, and therefore you think that there's a backlog of bills that could be out there because it doesn't fit with regular payment methodology?
Yeah, so they're separate things. The 105% of Medicare was to reflect two separate realities. The one that I like to point to, as I think is the more relevant, is that the Medicare fee schedule, the CPT methodology, doesn't apply well when you selectively take a group of patients with higher severity of illness and move them into one center through a system. The CPT methodology implies a spectrum of care within any particular code, and if you skew that in one direction, then 100% of the Medicare fee schedule is no longer a relevant number. The second argument around increasing the Medicare fee schedule was that it had been decreased by 8% per year, by 8% to 92% of Medicare for a long period of time because the fund couldn't absorb 100% of the Medicare fee schedule. And when the fund was able to absorb more, it was fair to make it up to the providers by moving to 105%. So those were the two rationales.
Okay. So it's not so much, I misinterpreted what you said before about the idea that somehow this was sort of an odd duck that didn't fit into regular hospital billing, and therefore there might be this pent-up demand of providers who hadn't actually billed against the fund
That
because
was, we've said that in the past.
Okay.
But I don't think that's necessarily something that that we've considered in our discussions recently over the issue. The issue right now is that the overall collection rates for providers for trauma patients has dropped, and that seems to be dropping within patients who were previously covered by the trauma fund, and that's because the trauma fund was paying better at 100%, even at 92% of Medicare, was paying better than Medicaid is paying, even though Medicaid is legally required in the state right now to pay at 100% of Medicare. So it's the reason for those discrepancies is threefold, as I pointed out, and understanding how to correct that and make it work in the context of the new system may imply a higher burden on the trauma fund in the future than it's currently seeing. And until we figure that out, we don't know what the $7.5 million surplus means.
Got it. Thanks.
All in favor to approve the release? Aye. Any opposed or abstentions? Good. Thank you, sir. Next agenda item is around the health information exchanges. Maryland law requires the MHCC to adopt regulations for the privacy and security of protected health information exchange through an HIE. The regs will first be released for informal public comment, and David will present the proposed draft regulations.
Okay, good afternoon, Mr. Chairman, Commissioners. I understand that I'm standing between you and the door, so hopefully this will not be a lengthy presentation or present too many challenges. So moving on to what we're really trying to accomplish. Staff seeks Commissioner approval to release draft amendments to the regulations. These regulations are really aimed at facilitating information sharing and ensuring protection of electronic health information that flows through an HIE. In this presentation this afternoon, I will be discussing the elements of the Consumer Access Draft Amendments. They largely apply to HIEs that choose, it's an important word, that choose to provide consumers with electronic access to their information. It is not requiring, said differently, it is not requiring that they make that information available. It ensures that HIEs offer access in a way that maintains the highest level of privacy and security of that information that's being exchanged, which is of value to the consumers. The draft addresses several key areas: electronic consumer access that pertains to view, download, transfer, control, submit, and it also requires HIEs to provide consumers with access to an electronic disclosures report. So thinking back how we got to this point, nationally there have been lots of concerns around the sufficiency of HIPAA and HITECH for a number of years. The draft regulations build on what exists at the federal level and enables secure information sharing. Staff has worked quite a bit of time, probably nearly 18 months, with an advisory group. We call it the HIE Policy Board. They provide recommendations to assist staff in framing the requirements which you have today before you as the draft amendment. If we think back to when all this started in terms of the regulations, began back in March, where the regulations of 2014 were adopted and amended one time in 2016. So the amendments, these regulations serve as, if you will, as chapters. And as technology changes, as modifications are made, different sections are added to the regulation. So it's not necessarily a static regulation that we wouldn't anticipate change over time. And if you wanted to get a sense of the number of HIEs doing business in Maryland, they're listed on the slide on the third bullet point. We have about 7 of them today. Typically, we consider CRISP to be the only HIE in many circles of discussion. It is the state-designated HIE, but there are a number of them that meet the definition in statute today. Over the following slides, roughly 7 of them, I'll describe at a very high level the key components of the draft amendment that staff seeks informal comment. The first area to talk about is access. In this area, HIEs must verify the identity of the healthcare consumer requesting access. So there's a process in which an HIE would follow to determine that I'm who I say I am and not trying to represent someone else. HIEs must allow consumers to authorize another person to have access to their information, such as a family member or a caregiver, which is logical. We see that in simply picking up prescriptions at a pharmacy, if you will. And there is no requirement that HIEs charge, but what there is a requirement that says if you are going to charge a fee for consumers, your fee has to be published so it's transparent, and it needs to be reasonable, and that can be determined at a later date what that cost should be. Moving forward to the next section under view access, this is where patient information is available for viewing, and what's made available for viewing to the consumers must also be what's provided to the healthcare provider. So it creates a sense of transparency. There isn't a sense of knowing that what the consumer has access to may be different than what their healthcare provider can see. An HIE must provide information to consumers that will assist them if they have any questions about their electronic health information. Sometimes patient information can be confusing, and where possible, the HIEs need to help clarify that. And the information needs to be presented in a way that's easy for the consumer to navigate and certainly understandable to them. The next area is download, transfer, or control of access. HIEs that offer consumers the ability to control how their information is released must follow generally accepted industry standards. HIEs that offer consumers this ability need to use standards that are typically used in other online applications. So what we're not creating is a one-off, if you will, that it's easily available and in standards that consumers use in other applications. As it pertains to the ability to submit information, an HIE that offers consumers the ability to send information to the HIE needs to be able to identify the source of where that information came from. They need to be able to make that information available to the provider, but not have that information override what the provider has in the existing electronic health record. So it supplements information. You might think of this coming from a mobile device. You might think of it coming from some sort of device that manages one's own health record, like a PHR, but it puts it into the HIE for availability to the healthcare provider. And a big area of interest to the Commission and to consumers is education. And an HIE must provide information to consumers on what information is needed for identity proofing. They must talk about the right to authorize a person of interest to have access to this information in the event that a delegate is appointed, as well as the right to review a denial of access to the information, and the level of consumer control over their electronic health information. Lastly, any advice concerning safeguarding their information is also a key requirement for educating consumers. The next area in which an HIE that offers this information must provide is a disclosure report that's electronic. Today, consumers can get that information by requesting it on paper. Similar to a credit report you might be able to access on paper, this now requires that to be electronic. So there's a time frame of about 6 months from when the regulations, or if the regulations are adopted at some point, to take what's available in the paper mode and make it available to consumers electronically. There is also an opportunity for exemptions, because this is not a requirement, but an opportunity for the HIEs to adopt. There may not be the capability for an HIE to meet all the requirements, but through some exemptions, be able to meet the spirit of it in alternative ways. So we've proposed recommending opportunities for the HIE to request exemption in various modes. And the decision for an exemption can be temporary, or it can be on a permanent basis, or essentially it could be denied altogether by the Commission. So where do we go from here? With the Commission's approval, staff will release the draft amendments for a 30-day informal comment. Staff will revise the draft after the comment period appropriately based upon the informal comments it receives. We anticipate being able to have these regulations as proposed regulations back to the Commission in early 17, probably over the winter months that we would see. So at this point, I'm happy to answer any questions that you might have or move forward from here.
Thank you, David. Questions or comments?
I'm happy to stand between everybody in the door. So you guys can go first. I don't care.
Sorry?
Okay. Are there mental health records going through the HIE?
The short answer is, it's a mixed answer. The short answer is we do not, the HIE does not take mental health records from providers that are providing mental health as their primary service line. But just to explain, if you're admitted at an inpatient visit and you're treated for any sort of psychological component, that would show up in the EHR. But also to clarify, there was lots of concerns years ago about carving out mental health records. And oddly enough, or maybe to the surprise of many, the behavioral health providers really want access to that information, more so than we thought. And also more consumers are interested in making that available. Now that said, we've not launched into connecting behavioral health providers, but many healthcare providers can determine there's a behavioral health issue by looking at the medications the patient is on through the HIE.
So I guess my question is probably, I do know there are some situations with mental health where the provider would not want the patient to review their records. And I don't know if there are similar circumstances outside of mental health or not, but is there any provision with consumer access for providers to make sure that if it's not, if they think it would be harmful for the patient to see the records, to flag it or have it not go through the HIE?
It's a great question. So think about this, the disclosure report and what's being made available on the disclosure end is just identifying who reviewed their record. The actual content of the record, the HIE will point the individual back to, it'll say Dr. Jones on 11/24, Dr. Smith, Mercy Medical, and it actually will point the consumer to the source as opposed to saying, here you go. For that very reason.
Questions here? Diane?
So your last comment makes me wonder. So when I, as a consumer, if I'm working with an HIE where I can access my records, or access the information in the HIE, the only information I'd be accessing is which providers have shared, or so I'm not actually getting at my medical information.
So we're starting small, and so the answer is that's correct. But we're starting small because all the controls that you need to put in place on day one to give a patient, a consumer, their entire medical record is enormous. But we also had a lot of pushback from providers that said, hold on, don't give them everything, send them to us. And what we do anticipate is at some point in the future, we will come back to you all and say, there's a balance here between what a consumer can digest and what you need to point them back to the treating provider.
So as a leader in an organization called the Patients View Institute, which hears from patients all across the country in terms of their experiences with healthcare, difficulties accessing medical records is a frequent topic and a frequent area of concern. Errors in medical records is a frequent concern from patients or consumers. So while this is wonderful, it's a step forward, I urge you to continue moving forward to support consumer access to their medical records. I think from an efficiency standpoint, taking an approach like this as opposed to making the consumer go to every provider separately and it's on paper and they get charged 39 cents per copy at this place and 59 cents per page at that place. I mean, it's a huge hassle. So please keep moving forward on this. The one thing that on the description here that I have a question about really most specifically is that if a consumer submits information to the HIE, it says that the HIE is not allowed, they shall not use the patient-submitted information to override or replace the health information submitted. I can understand that, but if what I'm submitting is, and
maybe this is not relevant in the sense that they can't actually see their medical record. If I'm correcting an error or I'm raising a question, what happens with that information that gets submitted? Does it go back to the provider? Does it just sit in the system?
It tags on to the existing record, on a care summary. So when the physician, Dr. Pollack, pulls up the record to see me, he's going to be able to see the clinical information that was submitted by other physicians, but also see a consumer amendment or a consumer component.
Or a comment or a question or
Correct.
something like that.
So it wouldn't supplant Dr. Pollack's information. It would add to it.
Okay.
And it would be differentiated into it.
Very helpful. The Hopkins electronic medical record system, which is wonderful in many respects. If a patient submits information, it's very clear that the physician doesn't see it.
Mm-hmm.
So it's raised the question. It's like, well, why collect it then? So it's helpful that then the providers would actually be able to see it.
And we really want to, when we started in 2007, the idea was to build, we even called it back then, a consumer-centric HIE model. But what we know is you have to crawl a long time before you run, and it takes a while to bring in the consumers. And we will.
David, thank you once again for a terrific presentation and great work you're doing for the commission. You and I have had this conversation, I think, before, and I don't want to bore anybody with this, but I do want to follow up on basically what Commissioner Sullenberg just said. The question, it seems to me, a critical question is who actually owns the record? In other words, I mean, I find this whole subject fascinating because it seems to me that, you know, the fundamental reality in healthcare is that ultimately it's the interaction between a highly trained professional, a medical professional, and a patient, a doctor and a patient. And the doctor is given a lot of very detailed information in many cases, very detailed information. And sometimes this information actually, aside from the whole question of psychiatric records and psychological records and so on, sometimes this is very, very sensitive stuff, right? The question is, when that record exists as a result of this interaction between the doctor and the patient, does the doctor own the record or does the patient own the record? Who owns the information?
So when HIPAA first came out, it's pretty clear that it's the consumer who owns the record.
Owns it. So the
and
property right is in the
consumer.
consumer.
And the provider maintains it. But then there's all kinds of categories of exceptions. For example, the provider can choose to, if they think that releasing information might cause harm to themselves, to another individual, or to the patient themselves, they can hold it back and not release it. It can be released to law enforcement under certain conditions.
Yeah.
So there's lots of conditions, but the spirit of it was to always say that the consumer owns it. And when we looked at building HIE in Maryland and largely nationally, the spirit of it was to create an infrastructure that doesn't challenge that integrity, but makes connections to where you have the consumers connected to the providers, and so they could really wrestle that out if there are those kinds of issues, and keep the HIE very neutral in terms of needing to get in the thicket, if you will, of the legal policy implications.
What conceptually, what is the difference between an HIE and a health information data bank, like a bank?
Sure.
Putting it into, you're depositing this information, right? Yeah. And this information, you know, there are people who have access to it. And if people have access to it, the question is there any way that you could facilitate the use of this information, let's say by de-identifying the data, for example, for research purposes, okay, in which perhaps the patient would actually be paid by the HIE for their contribution to the goodness and the welfare and the health of America. You know, is there any, in other words, if it is something like a bank, could we actually, maybe in the next stage of all this, start to go a little bit further in doing something innovative in this area? Because I think what you're doing is the Lord's work. I think we absolutely have to have security and privacy in these records. The question is, looking at it simply as a defensive mechanism and at the same time facilitate the interaction with other medical professionals. It's a great idea. Is there perhaps a way of actually building up a sufficient database that could be really useful for both medical research and also social science research?
So I like where you're going with your question. In fact, we last year, in the last amendment that we made, was to add a research component where information under certain circumstances would be available through the HIE for research purposes.
De-identified data.
Today it's de-identified.
Sure.
So we're thinking that way. But in HIEs, the difference between the bank and the HIE is the bank is not designed to push. It's designed, it would be designed for individuals to pull, so I could query the bank to pull, where the HIEs are designed to tell providers what's going on about their patients, oftentimes before the provider even sees the patient. So it's an alerting mechanism. It's very powerful in alerting and pushing data to that physician long before the patient ever gets in for population health purposes. There's so many reasons why pushing it out is better. To your point about banking, there is technology on the rise for what, if you're interested, it's called blockchain technology. It exists in the financial market, and it's starting to get peeled and dissected in the healthcare sector around HIEs, because it does create a pivot away from HIEs creating pipelines to more being able to create throughout the cloud sectors of banks, if you will, that keep them secure, because anyone that would try to hack into it, you couldn't get the full record. If you hacked here, you'd only get a part short piece. So I think that's where we're headed in 5 years from now. The dynamic of what an HIE may change, the definition of HIE, will probably change quite a bit.
Thank you very much.
Okay. All right. Thank you. And in the spirit of the previous questions and comments, I have a very practical question for you. And that is, where are we in Maryland with having an immunization registry that parents or others or anyone can access to draw down all of their immunization, which is a real headache every year for kids going back to school and for a lot of people.
It's growing. The HIE collects data on immunization.
Right. So it's there.
It's there. It is not mature yet. It's probably several years out from being fully mature, but it is being pushed to the HIE. It is growing. At some point, consumer access, that will be the answer. Consumers will be able to go in and access it.
It would be a such utility, and it's kind of non-controversial. It's in terms of prioritizing whatever it is to get the completeness of that data. And in fact, I think that would be a part of meaningful use to upload that. So I just think that that's, from a consumer standpoint, that would be a huge win to have.
Yeah, I agree. We will keep
that.
Yeah, but we'll keep that in front as we think about how we evolve in the HIE to get more consumer value. That's a very good point. Thank you.
So my first question is, I was reading through here, and it said notice of breach violation. So what is the definition of a breach?
So you can think of a breach in a manner, there's the technical definition, the working definition. Generally think of it as that someone who is not authorized has access to your medical information.
So the consumer has the right to know the percentage of risk available that their information has been compromised, or that has definitely 100% confirmed been compromised.
So consumers have to be notified when there's a breach.
An actual breach.
And when there's a breach, period. There's no.
If somebody holds the information hostage, that's not a breach.
Well, you'd have to breach it to get it to be hostage. Now, I think you might be suggesting if a provider refuses to make it available. Is that what you're aiming at?
No, I'm just thinking of nefarious somebody.
No, the HIEs are required under existing regulation, even federal requirements, that if there's a breach, you have to both report it to the federal government. In this case, you have to report it to the state, and the HIEs have to notify the consumer and provide support for the corrective action for the damages that might occur. And HIEs carry insurance to cover the liability as well on that.
Okay. My second question, the last time we met, we were talking about whenever we put something out for comment, that there would be a communications plan with other organizations to solicit comments, even if the comment is no comment.
Yeah.
This acknowledgement that somebody, aside from this body, reviewed it. So what is your plan?
So I anticipated that, and I thought I'd share how we did this last time. When we send it out, we have a network of networks, very much like your Facebook account. It'll hit. Last time we had over 200 organizations that received this information. So we hit all the associations, we hit the consumer groups, and they then redisclose or republish this information. So I'm pretty confident that at the end of the day, that it's really fully vetted. I mean, we've learned well over time to make sure that it gets out there. So it's not a narrow swath of people. We'll probably have more than 200 organizations that receive this.
Receive it, or is there any way to also ask specific organizations who have in the past been vocal on the issue that we would be interested in their comments?
Absolutely. We will make a point to make sure that's a part of the communication. I can say, if it helps, over the years, as we have found vocal, there are consumer groups or consumers, individuals. When they are vocal, we've always invited them into the process. So when I referred to the staff advisory group, a lot of these folks came in early on because they were the vocal ones.
Right.
So we keep looking.
Even if they're on the advisory group, I think just having their in writing
Sure.
acknowledgement that they have reviewed and are good with it.
Got it.
That would be a good thing to have on public record.
Makes sense. Thank you.
You mentioned the level of consumer control. What is their level of control over the site?
So today, consumers, you get either to participate or you can opt out. I mean, it isn't granular. Where we're headed for, and back in 2007, when we said, oh, this is consumer-centric, we thought out of the gate, consumers could control all the dials. They could control what information the provider would see and the providers that had access to that information. Unfortunately, building a system like that on the budget that states had, and even the federal government granted additional dollars to build out these infrastructure, was not nearly enough that would have ever enabled that. So where we're headed for now, under the work that's occurring today, is to probably 2 years, 3 years, to allow consumers to have the type of control that I just explained. Right now, if you were to go to a hospital or many physicians, at the bottom they have a statement that you want your information to be made available through Chris, then they'll check yes or no. And then the consumer can also opt out through other processes.
But they can't make any entries, like you said, right?
Not today, no.
And getting back to what Commissioner Sonneberg said, I think there are some downsides to the information available to patients. Typically, patients don't know how to interpret medical hoopty. You know, they take home message. Sometimes it scares them inappropriately. They may see the word carcinoid and they think they have carcinoma, things of that sort. I think the mistakes maybe you're alluding to are demographic mistakes. Are they in diagnoses and so forth?
Yeah, they are absolute errors. I mean, just as one example, well, I could give any number of examples. There certainly is the issue of the lack of use of plain language and the medical terminology that can be very confusing, no question there. But there's documented errors that when you do, I mean, the Open Records Project that was funded by the Robert Wood Johnson Foundation found that provider satisfaction went up, patient satisfaction went up, the accuracy of the medical records went up when there was direct sharing of all medical records between the patient and the provider. So I wouldn't underestimate the intelligence of the patient.
So is there a way for them to correct that? Go directly to the provider to correct that record?
Through that particular process there was, but in many places, as you acknowledge and has been stated, there is no way to correct a medical record. So I
think I hold out the HIEs as being promising for that, hopefully sooner than later.
Yeah, but to that point, I think that some of the communication has to go back to the point of origination of the data and to show what the opportunity is. Because I do think the errors, in my experience, have kind of come on both sides, where if you ask a consumer to kind of do a complete assessment that then goes ultimately in the electronic health record, usually a thoughtful clinician will add a fair amount of value in going that, explaining to the patient what more of the medical context. But then the exact reverse, what the physician shares, the output of the EHR, my experience, it's like 20% of the time or 25% of the time, there's substantial revision in either the story or the emphasis or what have you. And so there's just a fundamental accuracy issue in kind of improving that communication, where I think, from a policy perspective, I think that's one of the real opportunities, because if the record's not accurate, it's not helping anybody.
Right.
And yet, but that's really hard to measure unless you're sort of right in the front line. Yeah.
And frankly, if folks are interested in more information about this open records project, what they did, because it really is establishing the partnership with two-way communication to address the issues around access to medical records and corrections on both sides.
The particular problem is if these records are composed of just templates and the physician is checking, circles, it changes the way they think and the way they look at the patient, and they may be inadvertently checking something that they probably didn't ask or it's not correct. So it depends a lot on what kind of EHR the physician has in his office too, and the template. I think the templates are dangerous in private practice. In the hospital, it makes you think a different way.
So to Commissioner Stolenberg's point, we are moving in the direction of consumer control and consumer access, and more to come. But it has been a baby step process, not just in Maryland, but nationally.
Okay. Thank you, David.
Thank you. Do we need?
We don't. We do not need a vote. Yeah.
Thank you, Mr. Chairman.
Right. And you were not the last thing that was standing behind us.
Oh, okay.
Ben has the overview of upcoming initiatives.
Just a note on the consumer participation initiative that David and his team have done a phenomenal job. I think the industry has repeatedly said move faster and pointed to the consumers sometimes as being a bottleneck, and we've resisted that and really had extensive, comprehensive consumer participation throughout all of these work groups to the point of going through some of these draft regulations, not just those before you, but previous ones as well, literally line by line. So that, I think it's really, we make a big effort. There's always more to do, but it's in this area in particular, consumers groups are pretty engaged. Thank you for all for attending the administrative meeting, and next month, the earliest day of the month in which we can have a commission meeting, December 15th, and we'll have a presentation, we think, on our work with the network with Henry's work on the total cost of care. We've been working with 5 other regions to develop comparative information, and we hope that by next month that information will be approved for release by RWJ. I think it's exciting that we're getting comparative information from all payer claim databases across the country, and we can really look at the landscape of health delivery and variations in cost using not identical but consistent data sources. David and his team have been working pretty hard this month to go through the next round of telehealth grants, and they'll have recommendations for you for both the telehealth awardees and our first round of mobile health awardees with a focus on, in particular, on rural community initiatives. We'll also outline the primary care model that CHMH is leading in the state in conjunction with the the next version of the all-payer waiver. We think we can get some, share that with you. We expect that will also be released for public comment later this month, and we'll share that with you. We also, and this is a back to the future topic, that we have two mandate studies that are being done currently with the aid of an actuary. Historically, MHCC was required to report to the legislature on the cost of mandates that had failed in a previous legislative session, but were judged likely to reappear. So our actuary will be coming forward and we'll review those reports with you. One is on three-dimensional imaging for mammography, and the second is the diagnosis and treatment of lymphedema. I want to note that Janet Ennis has jumped back into this arena, although she is largely involved with the Henry and the SIO initiatives under Linda's team, but has pulled some time out to work with our actuary, and it looks as though the legislature is going to be interested in considering and is very much counting on the MHCC's input. And lastly, we'll be having our administrative team come forward with an assessment of where the distribution of our workload. That's in conjunction with the 4-year reassessment of how our fees, how we collect revenue through our authority under Maryland law to add a fee to nursing homes, hospitals, health insurers, and healthcare professionals. That's governed by the scope of our work across those 4 categories of providers, and we adjusted effective for the 2018 calendar year.
Thank you, Ben. Next comment?
Just in the spirit of Thanksgiving, I wanted to go on record to express my thanks and appreciation to Commissioner Moffett for an excellent job in the shepherding of the certificate of need for the Prince George's County project in UMS. I was recused from that, but I am a resident of the county, and I know it's a tough job, and I wanted to go on record to express thanks and appreciation.
One of these. I'd like to say that I'm going to work on my technology. But thank you very much, Commissioner Thomas. It's a heartfelt. I really mean it from the bottom of my heart. I really appreciate it. It was quite an experience. But I think that the result means that the people of Prince George's County are going to have a tremendous opportunity to enjoy a superior healthcare system in the future. And that was the point of the entire exercise.
Perfect. There's no further business. I'll entertain a motion to adjourn. All right, meeting adjourned.